Hello, this is Dr. David Nace. We are about ready to get started. Give us 1 second as people come on. We're about 600 and increasing. Great. So this is Dr. David Nace, Chief Medical Officer here at Innovacer, and welcome to the webinar. Healthcare will never be the same. Our look optimistically at the post-COVID optimism. So we think we can get a silver lining out of this. So let me introduce our panelists. Let me start with Jonathan Bush. Many of you know him as founder of athenahealth and currently executive chairman at Firefly Health and an advisor here for us and a board member at Innovacer. Jonathan, welcome.
Thanks for having me, David. I'm thrilled to have something besides baby chasing today.
And we also have, and I know the two of you are good friends, Dr. Stephen Klasko, who's been very busy of late, President and CEO of Thomas Jefferson University and Jefferson Health. Steve, welcome.
It's great. It's great to be on with you and my good friend Jonathan. This is the third of a few go-rounds, Jonathan and Steve show.
Never gets old. Never gets old.
So, but the environment's changed a bit. So what I'd like to do is just take a little bit of level setting as to where we are today, what's going on, get your perspectives, and then we'll kind of get into sort of what the future might look like. So let's get started. You know, everyone knows, obviously, that we're in the middle of a global pandemic, and the impact of that pandemic has been huge in terms of its cost and impact on our ability to deliver adequate health care. Steve, why don't we start with you? You know, you're in the middle of dealing this. We may be at the peak. Give us a little view of what it's like for you now.
Well, look, I think I can't have any of these discussions without doing a shout out to the frontline heroes at Jefferson and beyond. It's just been amazing. What I will say about us is, in some respects, we were really well prepared because, as you know, David, we've talked about healthcare with no address for a long time. And we had almost unlimited bandwidth and things like telehealth without much of a demand. And now clearly we've gone from 50 telehealth visits a day to 3,500 a day. But I'm sure for anybody out there that's part of a healthcare system, a traditional healthcare system, it's been apocalyptic financially. Because for those of us who don't have insurers, who are doing the right thing and are dependent on hospital revenue, it's literally worse than 9/11, worse than the financial crisis combined, as far as what it's meant to our bottom line. At Jefferson, we've done it without furloughing folks, without laying off folks, but it's going to be a huge after effect.
Yeah, and I know we've talked a little bit about the financial impact for healthcare systems. There's also the issue that the other players in the healthcare system, like payers, are looking at it from a very different standpoint now. But one thing I wanted to get Jonathan's input on here is there's another factor, which is the impact that our sequestration efforts have had on the economy. Jonathan, you've been involved with thinking about the economy, starting companies. What do you think this is going to have in terms of the impact for us going forward?
Well, there's obviously the bad news, which everyone's already covered 100 different ways. But I think that you got to look for the silver linings. And in this case, this may be the first sort of raising of the surfaces of the old economy without the use of war that we've ever seen in our human society. Most of the time, renewal comes from some sort of massive devastation. If we actually get out of this with the death rates that we're starting to see, when we finally, New York finally did a statistical sample rather than sampling the people at the hospital door, and found about what the Princess Cruise Company found, which is, about 0.5%. And if we're really 20% of the population through it, if we get through this with under 100,000 deaths, and we shake loose all of the kind of primordial fins of the old economy, whether it's we'll talk about healthcare today, obviously, but education, there's silver lining. There's silver lining.
No, absolutely. And the question we always have around where we've been, where we are now, and where we are going forward is, we've spent the past 20 years, Steve, as you often say, in the healthcare twilight zone.
Well, I think the reason I use that term is, you can't go anyplace. It's almost like imprinted on our lips, volume to value. Like I wake up and I say, good morning, volume to value. But when you actually look at what's happening out there, when I go and give talks for just about any traditional healthcare provider, I said, wow, you're all around that value, right? So how many of you have, all right, I'll give a real conservative number, 50%, no hands. When I get down to 10% of their revenue, actual true value at risk, I get some hands. So frankly, volume to value is still a philosophic and academic exercise.
Yeah, absolutely. And I love this slide that you provided me the other day. It's just we've been delivering Star Wars technology in the Fred Flintstone delivery system. Jonathan, we've always been asking around this volume to value issue. It's like, what's missing, right? Is it tech? Is it policy? So what's your view on this?
So it's absolutely, I've always said that nothing that we do in the delivery of healthcare, pushes the edges of science or technology. Obviously, in the invention side of things, that's different. But in the 99% of the procedures and care that we deliver, it's not like we're waiting for, Moore's law to allow the computing power to do a pap smear for Klasko's, patients or whatever. The issue has always been business model. There is, because of the wonderful things in medicine, the Hippocratic Oath and the social safety net aspects of it, these multi-mission, competing mission statements in the lobby. Only in a hospital lobby can you find a mission statement written that's like over a page long to summarize. And that coefficient of drag, well-meaning, comes from a good place, has prevented basically the demand curve and all the things that come from the demand curve from doing its work in medicine. And so you need shocks of some, various kinds to create black swan moments to let loose of things. So interstate licensing of doctors, suddenly all the governors are like, yeah, fine, if you'll practice, please take care of our patients. Telemedicine, everyone's like, fine, yeah, okay, I admit it was a big gig to get the claim up, and be allowed to do more procedures. Just do the telemedicine. All of these things we've known about forever, but we're finally moving, including social determinant data in front of it, putting social determinant data in the care record, as opposed to what procedures you did and for what claims and what palpation did you do to justify a level 4 versus a 3. All of that stuff is been known forever and written about and PowerPointed about. And Klasko, travels like Elvis around the world saying the obvious, and he doesn't have to work that hard because it's the same obvious for years, and he doesn't have to change the speech.
I appreciate the Elvis thing. I have to disagree with my good friend Jonathan on a couple of things. First of all, us obstetrician gynecologists do a few more things than pap smears, number one. Number two, Jefferson's mission statement is all of 3 words: we improve lives. Where I do agree with you 100%, getting back to the last maltreatment of an individual high risk has gone up incredibly. But that same person is accessing the system by getting on the phone and listening to 11 options to get an appointment 2 weeks from now. That's the part that makes no sense.
No, absolutely. I want to talk more about this, and I want to talk more about when you wake up every morning, Steve. And I love this cartoon. Is like, I think we should be more explicit here in step 2. Then a miracle occurs. So we're going to get into the silver lining. Maybe the miracle comes out of this pandemic. Let's first check in with the audience. Can I ask all the audience members, and of course you can submit questions whenever you want to the text box, please respond to this questionnaire and we'll take a look at the results. But how are you currently looking at your organization's response to the pandemic? Do you have a crisis plan that you're executing effectively? Do you have a response that was delayed because you didn't think about it for a while and then you're dealing with it effectively now? You're still struggling with that response, or really hasn't affected your operation? So let's take a moment for that question while we're waiting for this poll to happen. Steve and Jonathan, have we been waiting for a miracle to happen? And if so, how might this pandemic result in such?
I don't know if the word is miracle. We've been waiting for a black swan to happen. Most of the major transitions in our history are not from the incremental linear work of day-to-day improvement. They're from the big surprise wallop in the back of the head that came from a war or a recession or a shock to mortgages or whatever. And we're getting that now. And hopefully we'll be resilient and smart and take huge advantage of the improvement opportunities that come from it.
Well, I think the way I would look at it, David and Jonathan, is in some respects, not to be political, but I believe that Bernie Sanders was 100% right about the problem. We have a fragmented, expensive, and inequitable healthcare system that has just been exacerbated by the pandemic. I think he was wrong about the solution that government should solve it. But every health policy has just been, how do we pay for this fragmented, expensive, inequitable healthcare system?
Let's take a look at how our audience is dealing with that. We've got about 900 people on this webinar. Let's take a look at the results. We can pull those up. Interesting. What do you guys think about these results?
I think this is not, they're not baloney. They're not bullshitting. I think that a lot of the major medical centers, you know, both view themselves and act like quasi-governmental institutes. Some of them are quasi-governmental. But if you look at the JCO guidelines and the amount of oversight and coordination and reporting required, you know, most of the time it's an enormous pain and just life sapping. And then once in a million years, you actually go, oh shit, we have a binder for that. And let's go do the binder. And I think these are the moments, you know, in Boston, it was the Barrett Marathon bombing, when all of a sudden, all these hospitals that are costing all the employers too much money and are too bureaucratic and are too expensive, you know, there's not a dry eye in the state with what they were able to do very quickly. And I think that's what we're experiencing right now.
And David, I think the reason you got this response is because your question is, you know, is the now. And, you know, you and I have talked about this. We think at Jefferson, everything now, near, and far. And I think Jonathan's exactly right. Look, you know, we have 14 hospitals in the Jefferson system. Every one has a crisis plan. You know, we had a pan surge disaster preparedness group. We had 60 days PPE on hand. Not that we were predicting this, but, you know, we were ready for it. The question is going to become what happens near and far. You know, when Apple decided to no longer be a computer company, but be a digital lifestyle, nobody was worried about competing with them for the iPod. What they didn't understand is that if you were just making computers and you weren't thinking about the digital lifestyle, you were out of business. So I think if you ask this question 12 months from now or 24 months from now, were you prepared for the after effects of the COVID-19 pandemic and the Amazon moment in healthcare, you might get a different response.
No, that makes sense. And I appreciate you bringing up this analogy of Steve Jobs. So, you know, this is a great example. Like, if we can change the way we have with suddenly adopting telehealth and delivering care at home, can we move forward and change the industry or change the world? I know both of you have been trying to do this for quite some time. What's your level of optimism?
Mine is huge. I got to say, it's a horrible thing to go through. Horrible. But after 22 years of sort of screaming and getting sick of myself, a shock to the system like this could be, I mean, it won't be fun, obviously, and transformation will be hard, but the opportunity for dramatic increase to the efficiency of care, the ability for the same amount of caring to come in for a dramatically lower dollar point, which the society desperately needs, has never been more ripe than right now. Never.
I'm of two minds. I think that clearly this could easily be that moment. And I use this, you know, the slide you just put up is when John Scully, who was my commencement speaker last year, told the story about when he came to Apple and he asked Steve to do a 3-year, 100-page business and strategic plan. Steve Bates said, here's as far as you're going to get on a strategic plan. Year 1, we change. Year 2, we change the industry. Year 3, we change the world. And when you think about how they move from the old math of computers and operating systems to the new math of digital lifestyle, that's what we've done at Jefferson. We went from the old math of just being hospitals and a 2-campus university to the new math of partnering with folks like you and others on innovation and philanthropy. Here's the problem. As long as we have this fragmentation, though, between the payers and the providers, I'm not sure that that happens so quickly. Because if at the end of the day, post-pandemic, I'm getting paid $50 for telehealth visit and still getting paid $250 for an in-person visit, and these private docs who've seen their revenue get killed, when the patient calls and says, you know what, Dr. Klasko, that telehealth seemed to work really well, that doctor's going to say, I'd rather you come into the office. So the places like Kaiser and Intermountain and UPMC and Geisinger that have the insurer and payer and provider alignment, I think they will change even more rapidly. The fact that we have a situation where we have this group that makes sure the people that pay for the care get the care and that provide the care don't really talk to each other, and the providers are on one side, the employers are on another, that's the fragmentation that I'm not sure allows that Apple moment to happen.
Yeah. The other thing to remember is that when you have a black swan moment, these years are exactly reversed, right? When you're in a black swan situation, year one, the world changes. Year two, the industry changes. And year three, either you change or you join the dodo birds. In particular, that happens when there is an alternative to dodo bird. So we've lived most of our careers where the health system, there's no alternative to the health system. When doctors get in trouble, they go to, if the stormy sea, they go to the harbor's the hospital. They need a new operating room light, if they need a new 3D imaging, if they need a job, if they need an EMR, hospital. Today, in the last 5 years, we've seen $1 billion of private equity and VC go into alternatives to the hospital as a source of employment for doctors. We even have our first publicly traded and feeding himself grapes like Caesar telemedicine company, able to employ, 45,000 docs on their, roster, kind of roaring like a slow Uber. There's an alternative to WeChange that the hospital systems of the world have got to confront that they never had to confront before.
And Jonathan, I think the one other piece to that is, one of the things that we've recognized in Jefferson is, just like the old math and the new math of Steve Jobs, our old math had been our only math. Our old math was tuition for people to come into our campus at a ridiculous price to watch professors give PowerPoint, and patients coming into our hospital that some third party would pay us a lot of money to do. That's the old math. That's going to be a loss leader. So at Jefferson, we're leveraging our 3 million patient encounters to work with folks like you and Jonathan, but we don't do any vendor-vendee things. And I think that new world of we changing and the industry changing is true partnerships between providers and VCs, between providers and entrepreneurs. My first aha moment was when I was in Florida and the CEO and I worked with this company, a company like the kind that Jonathan started, and the founder came to me and said a year later, Steve, I want to take you out to dinner. I just had $1 billion IPO. I never could have done it without you. You helped me develop this. And I said, that better be a damn good dinner because you just had $1 billion IPO. So I got smarter than that. And now at Jefferson, literally, when we go to work with somebody, I would say, if you want us to help you develop this and be a major client, let's talk about what the partnership is.
Yeah, however, and of course, none of this applies to Jefferson, whose emesis bags have no odor. But the alternative today to then was the only place you could go to develop some technology was the health system. Then they all got vacuumed up by Judy Faulkner. Now they're in innovation-free zones because you can't break the Borg, et cetera. And there are these other sources of capital. I spend almost half my time with Firefly Health. This is a national health system. It's not just primary care. They're grabbing specialty visits through the cloud as well as primary care. They have the freedom to build Kaiser level of depth and get Kaiser size of whole dollar without getting to, even Jefferson level market share in any one market, because they can use it's suddenly broken the whole notion that healthcare is local when you get it virtual. Now, not all of healthcare is virtual, but think about how much really, most of us have some clinical exposure on this webinar, really how much of dermatology, cardiology, chemo oncology, think about this. How much of that stuff do you really, really need to actually have your hands on your patient's flesh to deliver well? And suddenly you're going, wow, this, if we really get virtual and we really break down this, state licensing Borg, the demand curve looks very, very different in medicine for health systems.
Yeah, no, absolutely. And I love this idea you have of innovation-free zones, because we've been experiencing that. And Steve, you and I have often talked about strides you made at Jefferson, but 20 years ago, we all know, that, geez, banking was no longer having to go and wait for a teller, that, we were able to bank initially at an ATM, then at home. But healthcare, we've just been stuck, even with the attempt to electronify healthcare. So what can we learn from the past? And Steve, more particularly, what did you learn at Jefferson, and how have you been able to leverage that?
Well, yeah,
Looks like we might have lost
look, this slide actually came from at Davos this year. The CEO of Bank of America came to me and said, 20 years ago, the two sectors that didn't get it were healthcare and banking. Now you're alone. And I think that at the end of the day, you look at what's happened with banking, it's a whole different ballgame. 30 years ago, we would have been talking about people lining up during the pandemic to get to deposit their checks in the bank, and obviously we're not worried about that. So look, the only thing that's different at Jefferson is we've taken, as you know, a model of healthcare with no address. It's hurt our revenue because of the traditional insurance model. But we believe that, just as Jonathan said, healthcare is going to start at home. We don't get up in the morning and say, I think I'll telebank this morning. It's just that banking got to the point of, if you can't do mobile deposits, you're not going to be in business. Now, to Jonathan's point, if every state needed a different ATM card and you had to walk around with 50 ATM cards in your pocket, that probably wouldn't have made it. Jonathan, I remember, you're cool enough that when I got you a ticket for the Super Bowl and I asked you to write me a check, you said you had to go up to your grandfather's attic to find a check because I didn't have Venmo. So I learned to become a lot cooler thanks to you.
I
that's
swore
awesome.
I would
I
never
think we
tell that. I can't believe I'm liberated from keeping that secret. The greatest high-tech hospital CEO ever didn't have Venmo. I wanted to tell everyone. I didn't say a word until this moment.
Well, speaking of Venmo, there's a lot we can do with people's smartphones. And Steve, I know you've been able to, capitalize on that at Jefferson.
Look, so it really gets down to this. It's there's a quote I like to use from Upton Sinclair. It's hard to get somebody to do something when their salary depends upon them not doing it. So when we created unlimited bandwidth for virtual triage, we figured we could get 60% of our patients that show up to my ED to not have to show up to the ED, either through telehealth, urgent care, or an internet appointment the next day. That would have killed us financially because we made an average of $1,500 from our insurers. Somebody showed up to our ED whether they needed to or not, versus the other way. What we did is we took our 35,000 employees and partnered with an insurer and said, for those employees, because we're self-insured, if you show up to our ED, it's a $500 deductible. If you go through Jeff Connect and we send you the ED, it's a $0 deductible. In 6 months, we saved $8 million. We had 65% of people that would have shown up to the ED not have to show up to the ED, and the patient satisfaction was through the roof. And as you know, David, the hospital 3 blocks away from us, Hahnemann, closed, an 800-bed hospital. All of a sudden, we got that influx of people that had been shot or whatever. It's an inner city ER, and we got 70% of those patients. The fact that we were able to offload patients that didn't need to be there. It all gets down to defragmenting the system. The reason that what Jonathan's done in his career has worked, the reason that Amazon transformed things is it defragmented the layers. And we have way too many layers in healthcare right now.
So you've often talked about this concept of a healthcare with no address. Both of you have actually alluded to this idea. What is the future here? Is it within grasp?
I'll just start, and I'm sure Jonathan has, this is what he does, but I think we have to get away from the fact people don't view themselves as patients unless they're sick. People are people. And I think that the new future will be that just like I have a bank that I have a relationship with. I don't view it as the place I need to go for a loan, but if I need to go for a loan, because that's where I do my mobile deposits, that's the bank I'm going to go to first because I have them on my iPhone. Jefferson, I want Jefferson to be the place that everybody can thrive without health getting in the way, that Jefferson is the app that they use while they're a person and not a patient. So that if they become a patient, they're not going to say, should I go to Jefferson or Penn? They're going to say, hey, well, obviously I'm going to go to Jefferson because it's right here. I'll get on Jeff Connect. I think I have a cough. I'm not going to go and look on TV or the billboard and see which place to go. So we've gotten rid of almost all our billboard advertising with the stupid pictures of the doctors on big billboards, because other than their mothers, nobody decides which hospital they're going to go to for cancer because of the TV ad on Morning Joe or the billboard. And we've done it all around digital stuff of getting, Jefferson is wherever you are.
Yeah, I'll build on it, but he nailed it, except that he kept using Jefferson. But there's three basic ingredients to building the healthcare delivery system of the next wave. One is supreme convenience, that you're available to people who aren't a patient. 94 to 96% of us on any given day are not patients, right? The second is that you're proactive. I would throw in that category that you're behavioral oriented. So 75% of spend is not cured by any stent, drug, procedure. It's lifestyle issues. It's the way you shop, exercise, sleep, etc. So anxiety, depression, sleep. So proactive behavioral support. If you do those two well, you earn the right to do three, just the way Klasko said. If you're instantly supremely convenient and you're proactively providing tidbits and nudges and coaching to your members to where they feel like they're a person to you, then when they get sick or they feel scared, they'll mash that button and you'll get to navigate. You'll get to, either if you're Klasko, send them to Klasko, or if you're Firefly, send them to the, handpicked, specialized, best place that you've decided to, be in your network. But that idea is very, very different from the center of gravity of medicine today, which people still, when, my wife has COVID, good friends who are doctors calling, let me know if you want me to get you in. They say, sincerely, as a favor, like, I'll arrange for you with your unbelievably high priced insurance to get the, to have the doctor deign to receive huge payments from, and they mean it well. Like, it's not, I'm sure, Klasko does this all the time. Hey, my wife's got this cancer. I don't know, all right, let me see what I can do. This concept is, hilarious in, God, I've got this $20 million. I'm looking for someone to manage, to get paid 1% to manage my assets. Well, let me see if I can get, you into Goldman Sachs.
You're
be at your house with flowers. The idea that we got to go this long in medicine with that notion still being a favor, I think that's about to hit obsolescence mucho quick.
So
I get five calls a week, David. I get 5 calls a week. I want to see this dermatologist. Can you get me in within 2 weeks? It'll be like, can you get me onto the Amazon site, Steve, because I really want to buy something.
Yeah.
So I've got a great story to tell you that's real time yesterday, but first let's just check in with our audience, because we are talking about this issue of convenience, digital care, virtual care. For those in the audience, all 900 of you, please check into your checkbox and just answer this poll question. What virtual technologies are you currently using? Telemedicine, as of now, because of the pandemic, that's part of your EMR, standalone telemedicine solution, one that you've purchased separately, a remote monitoring of medical devices from the patient's home, or are you getting data from Fitbits and other non-clinical devices like social determinants of care? So while you guys are in this very animated story, I have to tell you, I've had a lot of sun exposure with this head. And so I noticed a little bit of a palpation here where I couldn't see it. Yesterday, I took a picture of it. I went to my large healthcare system here in San Francisco. I did an online dermatology request. I got a request back in an hour. She took a look at the picture, told me what she thought the lesion was, benign luckily, but treatable. Told me that she already had sent an electronic prescription to my pharmacy, Walgreens, which will FedEx to me by tomorrow. Just so different than I would have experienced pre-pandemic. I mean, that plays right into the discussion you were having.
My wife is a Firefly patient and a COVID sufferer. She has digital O2. She has a little app. She has a team that monitors her, and she's got an oxygen machine delivered to the house by this dude in a big muscular guy with an incredible Hulk face mask on. Charming guy who set her up, and I, carry her around and run this thing. And if she gets really bad, we move her in. But that idea of being monitored, more frequently than you'd get rounded on in the hospital and treated, that's a non-existent thing, even 12 months ago.
Well, best wishes for your wife for sure, and obviously we were aware of that beforehand.
Don't forget me. Don't forget best wishes for me. I got the baby. I got to carry the wife. I got to cook for everybody.
Those are what
I feel
social.
I feel bad for that. I feel bad for that delivery guy that has to deal with Jonathan.
Oh, I was in there. I was trying to, how does this work? And is there a Bluetooth and how does it work? Mr. Bush, just let me plug it in and please step away.
Well, speaking of Bluetooth, let's check in with our audience and seeing if they're starting to use these sort of capabilities. Why don't we pull up the poll results now while we can see what our audience is doing in this regard. I'm just waiting for the poll. Here we are. Wow, this is interesting. And not surprising in the telemedicine solution, eh? What do you guys think?
Well, right now that word is a little bit like dyslexia. It means everything, but it means nothing. I think what's really needed technologically is a separation of the claim from the atomic unit of care. That right now all EHRs, even dear beloved Athena, grew out of the need to electronically defend a claim. And in fact, most care that you need for most chronic disease and most behaviorally determined health, 99% of it doesn't rise to the level of a claim. It's a nudge and a chat and a feed. And so it isn't that there isn't technology that will let you FaceTime and write about it on a claim. It's that the architecture of these technologies map back to a claim rather than to a condition or to a patient. And I think there's going to be a new generation. I'm actually working on a new company, just a pure developer kit, not selling to doctors or hospitals, just to developers who want to sell to doctors and hospitals, where the center of gravity would be that kind of thing. And I think I don't know what people mean when they answer these. I think probably all 1,000 of us have slightly different definitions of these things. But I think that's the thing that maybe in the next webinar we'll poll.
Yeah, and Steve, you alluded to before that this would be, our Amazon moment in healthcare, and I think this plays in here. So.
Yeah, but I think we make a big mistake, and we keep repeating the mistakes. I mean, when you think about it, the EMRs, and I agree with Jonathan, they're going to be probably the first technology that you get to spend a few $100 million to buy, so that you need more humans just to get back to where you were before as far as the patient-doctor interaction. And a lot of that is because when EMRs were being developed, we in the traditional healthcare ecosystem, doctors and others, weren't interested. In some respects, the same thing happened with telemedicine. We weren't interested. These companies get started and provide telemedicine. And again, what we decided at Jefferson with all of these things, I got tired of going to HIMSS and seeing 892 young people that look like Jonathan giving me a Hershey kiss and telling me how they were going to transform healthcare if I bought their system. And we just decided to literally bring as many of those systems together as we can as Intel Inside. So for us, Jeff Connect is a partnership with one of the big places, but they're the Intel Inside, and we co-developed and customized our own. So we're somewhere between a standalone telemedicine solution and our own.
That's exactly how I see it going for everyone, by the way. That's why I like Innovaccer. I know we're not supposed to plug, but I think that's the point, is that these EMRs were critical. They were part of the sort of Ages of Man exhibition. They're like sort of late Cro-Magnon, and you had to go through that. But they go from this dream of being the center to being, a claim documentation system that is more of a spoke than the hub. And then you end up with a more agile, scalable, and frankly, multi-health system hub that that's easier to build on. And that, every provider could come up with their own front-end developers, either rented or employed or, whatever. That migration is something I see the guys at Innovator having done well with their core original architecture. A little bit like having all the PPE in reserve. They've got a unified data model that will allow people to do this Jeff Connect concept where the center of gravity moves off of the claim and to the relationship.
So Steve, you brought up this issue about, UPMC, Kaiser, and, we don't all have that, right? They're not all paid viters. I hate that term, but you get what I mean. So, what's coming out of this, right? Because, a lot of as you pointed out to me in the past, a lot of the payers have already got their premiums paid and they're not having to spend money now. You guys are having to spend more money than you ever thought. What's coming out of this? What are the true types of partnerships that might make a difference?
Well, look, I think that I think first of all, we all have to think about how our company changes. So at the World Economic Forum this year, just to give you an example, the CEO of UPS was talking about how they need to become a 5G company. You say, well, wait, you guys are the brown shorts and truck people. Why would you need to be a 5G company? Well, because in their mind, deliveries are going to be 95% drones, and 5G is going to disrupt drone delivery, and Verizon and Huawei could become a transport company easier than they could become a 5G company. I think the same thing's true in healthcare. I think you're going to have to literally, if you're going to be a system, you're going to have to be able to provide the care from home, from somebody who is a person, not a patient, that wants to thrive without health getting in the way, have human contact with they needed, with continuous data rather than static data. I think the idea of a physical is ridiculous, that on April 30th of 2020 at 2 o'clock, my blood pressure is this, my temperature is this, my pulse is this, my EKG is this. So Steve, this is what you do for the rest of the year. My car gets better care than that. My wife's car, literally, while it's in the garage, is sending signals. When I wake up in the morning, I put it on and says, Steve, while you were sleeping, one of my tires got flat. It'd be great if you could give it some air. Meanwhile, I could die in my sleep with AFib because I don't have a T-shirt that's doing the same thing. So, but I think that in order for all of that innovation to happen, you have to you can't have just the Fireflies and the others doing amazing things outside of the ecosystem. And then having the insurers say, our job is to increase or decrease the medical loss ratio. Let's get as much in as we can at the beginning of the year, and let's pay out as little as we can at the end of the year. And have the hospital say, oh yeah? Well, you're trying to disrupt the system, Jonathan, and not have people come to the hospital. Sure, you're trying to get a lot of premium and not pay it out. I got to figure out a way to fill my beds and get a lot of expensive elective stuff into my hospital and compete with my biggest hospital competitor. That system is broken. It broke during the pandemic. And the question is, it really is a seminal moment. We can't go on with healthcare the way that it is. And with all these other people unemployed now, that are going to be on Medicaid, and every health policy thing has been, how do we get more people access to this screwed up system? And one of the things that when I got to meet our president, I said in the 30 seconds I had was, we need a 9/11 commission for healthcare. And that was even before the pandemic. But at 9/11, the Democrats blamed the Republicans blamed the Democrats. At some point, they said, we failed to keep the country safe. We have to say, we have failed to create an equitable healthcare system in this country.
No, and I think to the point that you made, and this is a recent quote from something you wrote that was published in Becker's, but that this crisis could, if we operate in the right way and pull it together, can accelerate disruption in that Flintstone delivery system that we've had, and how we pay for care and how we might perceive how that would have happened anyway, but we never really knew because we were in the twilight zone.
Yeah, and I think some of it is going to be, I'll just give you an example. we had an incredible collaboration. The CEO of J&J, Alex Gorski, is a good friend. We had an incredible collaboration with J&J throughout the pandemic of my being able to give him data of what was happening on the ground, him being able to explain to me, what was getting manufactured. Those are the kind of collaborations that if we could really continue, if the collaboration with a Firefly or a One Medical isn't ha ha ha, I can keep people out of your hospital, but is a how can I work with the traditional healthcare ecosystem so that when people really are sick, they're getting good and equitable care, but we're both trying to keep them out of the hospital. And there's some economic model that allows people to get better care for a lower cost. That's the winner.
I think that's right, and I think the economic model is that these companies like Firefly are creating national markets for what used to be local markets. And so, the bad news is that, virtual care and continuous monitoring and other things will make people go into Stephen's bricks less often, or anyone's bricks less often. And as digital technology for diagnostics gets better, there's going to be more and more that can be done in a cheapo urgent care where the Hollywood videos used to be. And, there's all kinds of pressures on that. But what there is on the flip side is Stephen can now sell the time and expertise of his specialists and his compounding labs and his rarefied high-end work nationally, really cheaply. Because if you have a One Medical or a I don't know what One Medical does, but let's pretend they're almost as good as Firefly. They can instantly click, thousands of cases of a rare type, perfectly suited to an individual, professor that Klasko employs, slipstream them into that guy's or girl's calendar in a way that used to be billboard ads or trying to milk, that particular size and type of cancer. How many of those could there possibly be in the greater New Jersey, Pennsylvania area? And now suddenly he can sell nationally, which creates real possibilities for health systems that seize it. The only risk is, like Boston Coach, does Boston Coach try to stop Uber, or does Boston Coach try to go and join Uber?
I think here's the rub. You have to be all in. When we invested $35 million in telehealth back in 2013, when people said, boy, that's crazy. One of the reasons it worked for us is I went to every chair, and these guys are very academic chairs and professors and deans, and said, you're only going to get any incentive this year if 80% of your faculty are trained in Jeff Connect and do at least one telehealth visit a month. That was in 2014. There was a mini rebellion. But the fact is we were all in. The problem becomes that people do these kind of things as hobbies. So, I'm X health system or I'm X university. All right, I guess I have to do some telehealth. So I'll buy this product so the doctor in Ohio can answer my patient's calls at 3 o'clock in the morning. Aren't I cool? I have telehealth. To us, that's not telehealth. To us is the same doctor that you would have seen. Why should you leave your house? And that's what played so well for us in COVID, because we were doing that before. It's just that people really didn't want to do it. They somehow wanted to come into Philadelphia and pay $50 to park and wait in the waiting room for an hour so they could see the person. But it wasn't that we couldn't provide it.
And maybe that's because that's what they knew, because inertia is always an issue as well. But your point's well taken. Jonathan, you brought up earlier, I want to come back to this historic issue of the social determinants of health being important. And I have to tell you, if HIMSS would have happened this year, every single vendor would have said they were a social determinants of health vendor, because that's the flavor of the month. Say a little bit about this, particularly because you're experiencing sort of a healthcare issue in your family today.
Yeah, I mean, COVID's a great example. It's sort of a hyperbolic or an archetypal example. We don't have anything particular we could do. Maybe the steroids, but proning and oxygen and constant monitoring and readiness, and we're 100 yards from a hospital that can intubate if we needed to. And she's got a, one 15-month-old child. This is a vastly better cure setting for her than, being in a stressed out lockdown situation. And we still can access that when we need it. That's a very high-end version of this. If you go back down through I can't sleep, which is going to lead to, diabetes through the binge eating, et cetera, those cycles, then it's really obvious. There's nothing you can do at a hospital or a doctor's office to sort of work on the anxiety that's causing you not to sleep, which is causing you to binge eat, which is causing you to not sleep, which is causing. Like those things that are driving our big three diseases just don't have a procedure for treatment. And if there's a way to get in and get a doctor tapped into the maple syrup tree, but not delivering each drip as it goes, but actually being available when moments of escalation arise, that's a huge improvement in the quality of life for doctors. It's much less depressing than be jacking through unnecessary or necessary in the negotiated settlement between the American College of Name Your Favorite Specialty and the insurance company, and actually just cutting through the nonsense and getting at the juice of disease and its cause. It's a big improvement in their lifestyle as well, if, as Stephen says, people can show up with an economic model that will reward it.
But the other issue of social determinants is the health disparities. We should be embarrassed, and Philadelphia is the epicenter of this. We have 6 great academic medical centers here, and we have the greatest discrepancy in life expectancy of any city in the country. If you go 5 miles west of Rocky versus 5 miles east of Rocky, it's 21 years difference in life expectancy. And that's because of food, education, and housing. And exactly as Jonathan said, that's not what the government, that's not what the insurers are spending money on. They're spending money on, oh, good, you have access for when you're diabetic, obese, hypertensive, whatever, you can get into Jefferson or Penn or Drexel, but not, hey, why don't we solve the problem so you're not diabetic, obese, hypertensive, etc.
I think
Massachusetts Medicaid actually costs the same amount PMPM as Blue Cross Blue Shield. It's the same PMPM. The rates are shit. You can't get an appointment, and it still ends up costing the same PMPM because they're banging against the emergency room door because everything that could have come first, there's no efficient mechanism for getting. So
instead, Jonathan, we got to get David to talk about data because that's what innovation.
I love data.
Yeah.
Well, I mean, if we're going to address social determinants of health and we're going to start getting data from your T-shirt, you got to start thinking about data. And certainly we at Innovator, and both of you know this well because you've been very helpful in working with us, it's how do you bring in data from everywhere? And Steve, to your point, how do you bring in the community health organizations? How do you bring in other forms of data besides pharmacy and labs, like, not just your T-shirt, but, whether or not you can get transportation or your housing, and how do you identify those people that are vulnerable, what their obstacles to care are? And from our point of view, the issue has been, how do you bring in all the information together and leverage it to members of the team?
So I think there's very briefly three components to this. One is the interoperability of the data, and we could wax poetic on how bad that is and the fights between the government and Epic and some of the other stuff. But the things like the fire layer or the kind of stuff that you're doing will start to help that. So that's one. The second thing, it's hard to get somebody to do something when their salary depends upon them not doing it, also gets down to people that run systems. I love the fact that I can look at most hospital systems websites. It's all about, inclusion, community engagement, social determinants, and innovation. And I say, oh, good, CEO, how do you get incentivized? It must be community engagement, inclusion, social determinants, innovation. Oh no, it's hospital census, EBITDA, U.S. News and World Report. So if you want to look at what a hospital is going to look like 10 years from now, ignore the website, ignore the board, and look at how the CEO gets paid. Again, I know you don't like me to mention Jefferson, Jonathan, but 25% of my incentive is decreasing health disparities in Philadelphia that I have no control over. So that's forced us to share some data with the different groups, the underrepresented groups. Esperanza is a Latino group in Philadelphia that does a lot of work, Project Home, the homeless group. So we started a data sharing piece with them. And then the third thing really gets down to that fragmentation of data. One of the crises of the pandemic was we had good collaboration between the different healthcare systems, but they all had different data systems. And we literally were in a situation where we were putting our paper data things on Microsoft Teams to share with other folks because we had Epic and they had that lousy, I think it was called Athenahealth or one of those other systems that wasn't Epic that just didn't
Not like it
interoperate.
used to be, believe me. Uh, yes,
You know,
right. Could I just, first of all, Jefferson's amazing. Love Jeff. Everyone loves Jefferson. Have a poll. Who loves Jefferson? 97. It's great. There's a distinction that I think we need to start building in the data world. Everybody keeps talking about pipes, interoperability between disparate systems. That's fine. That's a generation like the EMR. It's sort of the generation after the EMR. There's the EMR generation, then there's the pipe generation, right? But then there's going to be a platform generation. What I like, one of the things that's cool about Innovator is a little used corner is this, I don't know what you call it, in the API or something, where health systems can actually build their own apps on that stack where they only have to be front-end developers. Now, instead of ingesting data and rationalizing it and cleaning it and scrubbing it and making decisions about all the stuff that was used to defend a claim, whether you need it to cure cancer, you can actually have data born and live on your stack for your own use, natively integrated with that stuff. And that notion of a platform company is the one thing I wish we had maybe that's a thing that people need to start thinking about. What is there that I can actually build natively on?
This gets confusing to so many people, and I think both of you know the name Innovator as our company was Innovation Accelerator, and the whole comprehensive issue was how do you get all the data in one place and then innovate on it? And certainly Jefferson's had a strong focus on innovation, but the data allows you to, these terminologies get confusing to people. An API is really just a mechanism for different information systems to communicate with each other, and FHIR is really a common language they can use. And so we've been really thrilled here to have the nation's first comprehensive FHIR-based API platform, which actually can help support workflows and analytics and really alleviate, I think, the burden, the friction that we've had in healthcare. So we've been pretty excited about that. And a lot of people get confused about what is FHIR, what is API. So I appreciate, Jonathan, for your bringing up the clarity of how that can really move us toward true interoperability. So with that said, just to sort of wrap up, I think coming out of this pandemic, we've talked a lot about, virtual care, healthcare with no address going mainstream, getting a hospital without walls a reality, and collaboration between multiple stakeholders, maybe payers and providers, will be the new breakfast, if you will, for innovation. So I do hear optimism from both of you. Is that correct?
Yes, I think, obviously we can't. We're in this pandemic, right? So relieve us from opining about whether it would be nice to have a pandemic. It's just horrible. But from the depths of it right now, is there reason to get excited and see this horrible thing as an opportunity? Absolutely.
And I guess what I would say, and you and I have talked about, I'd given a talk around dispelling the myth of non-disruptive disruption. And the reason I said that was because I'd given a talk for the European Health Forum, and one of the health ministers said, well, I believe in everything you're saying, but we like non-disruptive disruption. Every time there's been a major change in an industry, there have been winners and losers. And so the optimism that I feel is because we're willing to be flexible and recognize that we might not be right today, but we're going to think about what's going to be obvious 10 years from now and do it today, and use the pandemic as an accelerant as we move forward. But I think to think that healthcare is going to change and become, cooler and easier and without walls, and everybody's going to be okay, that's not going to happen. That's really not going to happen. I think that's been the mistake that we've made, whether it's the Democrats or the Republicans, around, let's just give everybody this messed up healthcare system. Let's not upset pharma. Let's not upset the insurers. Let's not upset the providers. Let's let the entrepreneurs make new things, and let's just put it all into a bowl. And we want everybody to be happy. That's not going to happen. Taxi medallions are not happy after Uber. Some hotels are not happy after Airbnb. And every one of those things created winners and losers. And I always tell my folks, I want to be Target and Walmart. Because at the end of the day, when Amazon disrupted retail, there were some folks that said, oh my God, nobody's ever going to a store again. We have to be all E. And we don't even hear about them anymore. there was Macy's, Sears, and Penny's that said, boy, what a fad. Well, Target and Walmart said, we're really good at what we do, but we also have to be at home. At Jefferson, if somebody has pancreatic cancer, they don't care what my telehealth thing is. They want to go to the best person to do a Whipple procedure to potentially live as long as they can. But I also want to be that place for that person that just wants to thrive and not have health get in the way, and have both of them view Jefferson as their partner.
I think that's right, and I think the idea of, what was between the lines of that statement is that many retailers went away, and in order for healthcare to be more equitable, to move ourselves onto a demand curve that reasonable middle class, non-rich people could actually participate in, much bloat, and a lot of that, health system bloat has to go away. And the ones that remain have to be much more lean, much more virtual, much more connected. So everyone on this call is probably connected to one of those health systems. And maybe that's depressing. Gee, maybe it's going to be us that dies. But really, we're all going to die anyway. Like, the opportunity that this may be the moment to figure it out, to play, to me, that is life affirming. And it is going to make everyone engaged in this next chapter really remember these next 3 years. Like, tell their grandkids about it kind of way.
Just for final thoughts, we've got time for each of you to just kind of wrap it up and say, what would your advice be for our audience? If people are just in the trenches dealing with this, we've talked about a lot of things: innovation, disruption, social determinants of care, digitalization, virtual care, winners and losers. What is your advice? Let's start with you, Steve.
Well, I would just say, think about everything else that you can do in your consumer life and how it has changed in the last 10 years. And then think about how you can't do that in healthcare. And then, if everybody could recognize that there's nothing special about health that couldn't happen. The technology exists. It's just that we have gotten you to believe that it can't happen in healthcare. I did I did a blog where I talked about that people have too much respect for their doctors, and I got a lot of guff for it. But the fact is, I said, if you have an appointment at 8 and your doctor shows up at 8:45, 95% of the time, patients say, "That's okay, Dr. Klasko, you must have had an emergency." That's true about 12% of the time. The other 88% of the time, it's just that I know if I show up 45 minutes late, you'll excuse me. If I was your real estate agent and I showed up 45 minutes late, you wouldn't excuse me. So I think we have to stop looking at healthcare very much different than other consumer entities, other than the fact that when you're really sick, it's not a consumer.
Jonathan, a quick closing tidbit for the audience before we close.
I gave my huge close on the last one about the moment in your life that you'll tell your grandkids, I'm not going to get another. That's
left.
Stumbling stop. No, I do think they're always in life, especially if you end up working in established chunks of society. And you do well, you end up in a kind of a well-liked, established place, and healthcare systems sort of fit that description. And there's always a temptation when you're at a well-established place to defend your position rather than attack the next one. It's just the nature of things. It is homeostasis. It's cell integrity. It goes to every atomic level of who we are as people and as tribes of people. And fundamentally, the human condition, the great challenge is to not defend, but to attack, to not try to not have to move for as long as possible, but move earlier than you have to, so that you get to a new mountaintop and see the new milk and honey. And everyone in healthcare has got, with this pandemic, the opportunity for that move to be right now and much bigger than it has been in any of our careers. And I hope a few of us take it.
Well, I think that makes a lot of sense. We are 1 minute over. I just want to close by thanking both of you for attending today, and thank you to our audience. We still have 600 people online, even though we've gone 2 minutes over and people are so busy. Jonathan, thanks so much. Steve, much appreciated.
Thank you.
All right, and great. And that concludes our webinar. Thank you all for attending. We'll see you at the next webinar.